A very good evening, colleagues. The time is 6:30. The time is 6:30. Welcome to another CPD presentation hosted by Intellectus Campus. My name is Avacare Health. I serve as the General Manager of Intellectus Campus, a group of entities. We are a skills development and training entity that has a special focus on health and social sciences with a footprint in 5 countries, namely South Africa, Namibia, Zimbabwe, Eswatini, and Botswana, with our footprint soon to be extended to Zambia. Before we resume this evening's session, just a couple of housekeeping requirements. Colleagues, if you refer to the chat, there is a link on the chat. Kindly complete your details on the link to enable us to capture your attendance accordingly. Please do not share your details on the chat. Please refer to the link to enable us to capture your attendance details. Secondly, whilst looking forward to this evening's session, which is a panel discussion. We really invite discussion and commentary from the audience, either by way of raising your hand so that the team of moderators from Intellectus could recognize you, or if you could please indicate or type out your question or comment on the chat so that we could recognize you. Overall, the panel discussion is intended to be as interactive as is possible. Allow me to follow the following process. I am going to introduce Dr. Tadesse Mekonen. Thereafter, hand over to our clinical director in Intellectus campus, Dr. Jackie Stone, to run a snapshot of introductions for the remainder of our panelists. Dr. Tadesse Mekonen is the executive director of Avacare Health and has played a leadership role in successfully launching the Namibian HIV clinical mentoring program. Additionally, he has successfully led all the preparatory work for and launched of the HIV test and treat pilot in Namibia, including development of implementation protocol, evaluation protocol, monitoring and evaluation framework, activity planning, and budgeting. He also won the Young Investigators Award for Clinical Science, Care, and Treatment category at the International Conference of AIDS and STIs in Africa, ICASA 2015, for the work done in early pediatric HIV treatment, viral remission, and proviral DNA reversion. He has successfully trained and coached clinical mentors across the country, supported the establishment of adolescent-friendly health center for the HIV-infected adolescents in Oshakati Intermediate Hospital in Namibia, and supported the strengthening of pediatric HIV care, treatment, and pediatric HIV disclosure. Amongst many of his achievements, he has led the successful launching of the ECHO model of virtual training and mentoring in Namibia, with close technical and financial support from UNM, CDC, ECPAF, UW, and ITEC. This is the first ever ECHO launch on the African continent, and some African countries are showing interest to replicate the practice to their settings. A warm welcome, Dr. Tadesse. Good evening.
Good evening.
T, before you pitch in, if I may also request that Dr. Jackie Stone do a snapshot introduction of the remainder of our panelists. That is Dr. Agnes Katsitsira, Dr. Enos Moyo, Dr. Agri Mwemba, Professor Lloyd Mulenga, and Dr. Cleophas Chimbetete. Good evening, Dr. Jackie Stone.
Thank you, Obi. I'm not going to go into the extensive CVs of all of our panelists. I'm sure people in the individual countries know them well. So we have two of probably the top HIV doctors in Zambia. Professor Lloyd Mulema represents Zambia Ministry of Health, and he is on too many groups, including PEPFAR and a number of others to mention. Dr. Egri Mwemba, who works closely with Dr. Mulema, is a nephrologist and is very experienced in the effects of TDF with the kidney, which is going to be the focus of the talk. I've put some cases in the chat just to illustrate some of the issues that have come up. Dr. Agnes Katsitsira runs the Center of Excellence at the Perinatal Hospital in Harare, which is our state hospital. And she is qualified at the University of Zimbabwe She also has a diploma in HIV from South Africa, plus she has an MBA and a string of qualifications that are, again, too long to mention. She's very well known in Zimbabwe. She's also the Secretary General of the College of Primary Care Physicians in Zimbabwe. Dr. Cleo Chimbateti is the president of our public health physicians. He's a very experienced HIV clinician. When I first returned to Zimbabwe, he taught me about HIV, and he is an extremely humorous and excellent presenter. And I'm looking forward to hearing some of his answers to some of the questions, particularly involving HIV in what is now an elderly population. I watched him present at the Zimmer conference recently, and his knowledge is quite extraordinary. Dr. Enos Moyo, we are proud to say, is Zimbabwean. He is working in Oshakati at the moment and is extensively involved in HIV. So we are very privileged to have two Zambians. Dr. Tadesse, we're calling you Namibian at the moment. So we have two representatives from Namibia, and we have two representatives from Zambia. And I think that the panel discussion could be extremely interesting. And I really do encourage everybody on the call to start preparing some questions, because it is extremely unusual to get this level of expertise in one place at one time. So I'd like to welcome Dr. T and all the panelists, and I really do look forward to this presentation. So Dr. T, the floor is yours.
Thank you very much, Dr. Jackie, Obakeng, and the entire Intellectus team. Again, thank you for creating this opportunity for learning as a community. We are here to make presentation and to facilitate panel discussion, but it's not like we know everything. So we learn together, and we effectively have a community of learning that can transform HIV care and treatment. It is an honor and a privilege to be with you all, 200 plus colleagues from every corner of Zambia, Zimbabwe, and Namibia. I'm happy to be called as an Ethiopian and a Namibian. I love Namibia. So colleagues, what I will try to do this evening is, Dr. Jackie, can you kindly confirm if you can see my screen in slide mode?
We can see it, and it is in slide mode.
Thank you. Thank you very much. So colleagues, to save time for the panel discussion, I will quickly go through this presentation. I don't think this would be the first time I might have presented this to some of you. And this is not really new data we're going to talk about. This is data that accrued over time in the areas of safety, efficacy, and other associated emerging adverse events in the use of TAF versus TDF. So we try to answer some of the unanswered questions that lingered over the years. So this is the outline of this presentation. We'll go through the key questions, and we'll look at the dichotomy of the plasma intracellular concentration of tenofovir from TAF versus TDF. We'll also look at some of the data on the use of TAF in both treatment-naive patients and also in treatment-experienced patients when they switched from TDF to TAF. We'll touch on weight gain with TAF, and then also the issue of the PK parameters of TAF when co-administered with rifampicin, and we end off with HIV and hepatitis B co-infection in terms of the use of TDF and TAF, which was a question that was never answered until last year. So key questions: what's wrong with TDF? How are TDF and TAF different? Is TAF now currently being recommended as part of first line anywhere in the world? How safe and efficacious is TAF in treatment-naive patients, also in treatment-experienced patients, and how bad is the weight gain and the like? This slide is really very important for us. I hope you all see it by now. Tenofovir as an active drug is very poorly bioavailable. If you hypothetically think that this is the gut wall, the efficiency at which tenofovir can penetrate through the gut wall and be available in the plasma and on the tissue side and in the intracellular space is really negligible. For this reason, tenofovir has to be packaged in a way with a prodrug, in a form of a prodrug, either with a disoproxyl fumarate or with alafenamide fumarate. TDF, tenofovir disoproxyl fumarate, has been used over the years at 300 milligrams, but it is readily absorbed across the gut barrier from the blood and readily available in the plasma, and a small concentration that is required in the intracellular space in the cytoplasm, where it inhibits reverse transcription. As you could see this, the biggest concentration of tenofovir that actually comes from tenofovir disoproxyl is off target, outside of where it is required to act. And for this reason, there is significant risk of bone mineral density loss and renal tubular dysfunction. But when you look at tenofovir alafenamide fumarate, which is a real novel prodrug, it is packaged in a 25 milligram that is effectively more than 12 times or 12 times less than the 300 milligram tenofovir packaged in the TDF. As you could see, it readily penetrates through the gut wall, gets into the plasma, and the biggest concentration would be in the intracellular space at the target site, and a small concentration of tenofovir will be circulating around or wandering around in the body and possibly causing some much lesser degree of toxicity as compared to TDF. So this is where the gamble is in these two prodrugs, and we'd see how this was actually now replicated in science evidence and in clinical practice. Now, the first thing, in evidence science, in evidence-based medicine, clinical practice guidelines would be at the top of the pyramid because they inform practice based on weight evidence with external validity. To this end, we asked the question if TAF is recommended as part of a treatment regimen anywhere in the world, and both the Department of Health and Human Services of the United States, as well as the International AIDS Society of the United States, have been recommending TAF as part of the preferred antiretroviral regimen for years now already, which is encouraging. And if you look at the European AIDS Clinician Society, they have also been recommending the use of TAF as part of a preferred antiretroviral therapy with a few different choice of anchor drugs in their treatment. So this is not new. It has been recommended as early as, to my knowledge, maybe late 2016, 2017 in some parts of the US and Europe. Now that part is answered. Yes, it is not new drug. It is been recommended in preferred antiretroviral therapy in adults with different comorbidities and also with no comorbidities. So what did the safety and efficacy data show in patients who have never been treated with any antiretroviral therapy in the past? One of the studies that I would like to refer is this. One of the first studies that actually randomized antiretroviral naive patients who have never been on treatment with detectable viral load of at least 3 log, 3 log or more, and had any level of CD4 count and relatively healthy kidney function as estimated by the glomerular filtration rate. Randomized 1-to-1, it was double-blind study. Patients were followed over 144 weeks. And the findings, and the study was an inferiority trial to see if tenofovir alafenamide fumarate containing antiretroviral therapy could achieve comparable viral suppression at week 48 to start with. And that endpoint was, that cutoff was at copies of 50 per ml. They also had safety parameters, serum creatinine, which I don't believe is a great indicator to measure the degree of tubular dysfunction caused by tenofovir disoproxyl, but proteinuria is good. Bone mineral density for the hip and spine bones were also looked at. As part of this study, they took a sub-study population to look at the PK characteristics of tenofovir disoproxyl versus TAF, and the findings were very interesting. The orange, the amber curve, which you see here on top, is the plasma concentration of tenofovir that emanated from the administration of tenofovir disoproxyl containing antiretroviral therapy. And the purple curve down here is the tenofovir concentration, the plasma that emanated from patients who received actually TAF-containing reagent. And you can see the difference. There was a 91% reduction in the plasma concentration of tenofovir when TAF was given as opposed to TDF. This is very compelling. And we may start to wonder whether TAF would work. But it is not the plasma concentration that matters. In fact, this finding was actually proving what we said early on, what we illustrated early on, that we get much of the tenofovir that we don't need from TDF. And you would see that the intracellular tenofovir diphosphate, which is actually the final metabolite that would inhibit reverse transcription of HIV-1, if you see the proportional concentration, there was a 4.1 times higher intracellular tenofovir diphosphate concentration when TAF was given at 25 milligrams as compared to when TDF was given at 300 milligrams. This is the most important aspect of the PK study. In terms of viral suppression at 48 weeks, I will go through this quickly. There was no significant difference between the two groups. In fact, the finding was that patients who received TAF had slightly higher rate of viral suppression at 46 weeks. Unfortunately, there was no free lunch. Patients who received TAF had significantly higher level of total cholesterol, low-density lipoprotein, and also triglycerides, while there was also slightly higher HDL level. This finding is consistent also in the switch studies that we'll see later. And also the total cholesterol to HDL ratio was not different between the two arms. However, despite clearly higher total cholesterol, LDL, and triglyceride level in patients who received TAF, the proportion of patients that required the initiation of lipid-modifying treatment was not clinically different between the two groups. In terms of renal parameters, we believe that the toxicity of tenofovir disoproxil or tenofovir starts off with injury of the proximal convoluted tubules, which are essential to absorb some key proteins from the tubular lumen back into the interstitium of the kidney. And whenever we see a very high level of proteinuria, then it is an indication that there is tubular dysfunction. But this dysfunction can progress over time to actually cause possibly glomerular dysfunction that would be shown by, slowing down of glomerular filtration rate, which is estimated here with these two equations. And the CKD-EPI equation is believed to be a more accurate equation. And you would see that patients who received TDF had a significant slowdown of the glomerular filtration rate as compared to patients who received TAF. Or significant number of patients or proportion of patients have decreased GFR as compared to patients who received TAF. Interestingly, no patient who received TAF actually discontinued therapy due to renal dysfunction that would have necessitated treatment interruption. And then there were 4 patients from those who received TDF who actually interrupted treatment, 2 due to renal failure, established renal failure, 1 due to decreased GFR, glomerular filtration rate, and 1 was nephropathy. Now, breaking this data further down, if we look at different markers of proteinuria that are very sensitive to pick up a proximal tubular dysfunction, including retinol binding protein to creatinine ratio, beta-2 microglobulin to creatinine ratio, or even total urine protein to creatinine ratio. In all cases, you would see that the amber curve is higher than the purple curve, showing that patients who received TDF had consistently, by all parameters, progressively had more and more proteinuria. As we all know, fully established chronic kidney disease is not reversible unless there is transplantation. Using dialysis and other disease-modifying agents, we may slow the progression to end-stage renal disease and renal days, but we can never undo chronic kidney disease. So you can already see that the degree of proteinuria and tubulopathy that emerged or that was associated with the provision of TDF in these HIV patients. In terms of bone mineral density loss, you would see that the amber curve actually is often lower than the purple curve, showing that there was more bone mineral density loss in patients who received TAF. The second study that we'll be showcasing today in treatment-naive patients between TDF and TAF was the AMBER study that recruited HIV-positive adults who never received treatment, detectable viral load, and CD4 count more than 50, and reasonably healthy kidney. Randomized 1-to-1 over time in a double-blind placebo-controlled trial. At week 48, patients were moved to TAF arm, having seen that TAF is comparably safe and efficacious. An inferiority study, again, with an inferiority margin of -10%, you would see that at week 48, there was no difference between the two arms in terms of viral suppression to levels less than 50 copies. And looking at the treatment, if the difference, the 95% confidence interval for the difference on the effect size between the two groups, which is crossing the zero line, showing that there was no statistically significant difference in the proportion of patients that suppressed the virus at 48 weeks. What we deduce from this is that they had demonstrated comparable efficacy in viral suppression in treatment-naive patients. Disaggregated by baseline viral load, there was no difference, and also by baseline CD4 count. Looking at the glomerular filtration rate at 48 weeks compared with the baseline, remember these were treatment-naive patients. Patients who received TDF, the green curve, had on average lesser glomerular filtration rate, the speed at which the kidney excretes unwanted waste from the body was slower in patients who received TDF as compared to TAF. In terms of proteinuria, again, you would see that the retinol binding protein to creatinine ratio, a much, much higher ratio as compared to TDF, as compared to TAF. In other words, patients were at a very, very high risk of developing tubulopathy in patients when patients received TDF. Again, bone mineral density loss, you would see that patients who received TDF had significantly lesser bone mineral density at 48 weeks, after 48 weeks of treatment with TDF as compared to patients who received TAF. This was not only the case in spine bone, but it was also the case in the hip bone. So now answering the first question, is TAF safe and efficacious in people living with HIV who are naive to treatment and are given TAF? Yes, we have demonstrated that through those two groundbreaking studies done earlier during the days. Now, okay, treatment-naive patients are distinct from treatment-experienced patients because treatment would bring in so many changes in the way that the viral dynamics, the immunity, and several other things and patients also would behave differently. So testing the efficacy and safety in patients who have actually been treatment experienced is very important, also to indicate its use in maintenance therapy. So there have been several studies that looked at the efficacy and safety of TAF when patients were switched from TDF to TAF. So I will go through this rather quickly for the sake of time. One of the studies that actually switched patients from TDF, as TDF, a backbone drug with different other anchor drugs, but the combinations of various ones, including boosted atazanavir, patients were randomized into 2-to-1. 2 times patients received TAF and 1 time the patients received TDF and followed over time. In this case, TAF was given at 10 milligram, but it was pharmaco-augmented with cobicistat of 150 milligram. And their intention was to see the proportion of patients that maintained viral suppression to copies less than 50 at more than or equal to 96 weeks. Remember, these are all patients who received tenofovir with disoproxil several months and maintained durable viral suppression. So they have undetectable viral load at the start of the study. And at week 48, actually there was no difference in viral suppression between the two. However, when they looked at there was 97%, 93% viral suppression, but when they looked at the treatment difference, the 95% confidence interval for this effect size, the effect is viral suppression. The difference is the difference in the proportion of patients who suppress the virus over 48 weeks since randomization. And you will see that this is the 95% confidence interval for the treatment difference between the two arms, and it is both the lower margin and the upper margin are on one side of zero. It's not crossing. So what this tells us is that there was significantly higher proportion of patients suppressing viral load when they were pushed onto TAF. It doesn't show superiority because it is not over the 12% margin, and the study was not designed for superiority, but for non-inferiority. But at least you would see that there is a trend towards superiority in viral suppression when patients were moved from TDF to TAF. Remember, these are treatment-experienced patients. So we're talking about maintenance therapy. In the same way as we saw in patients who were treatment-naive, there was significantly higher increase in the total cholesterol, low-density lipoprotein, and triglyceride level in patients who were moved onto TAF. The proportion of patients that actually required lipid-modifying agents were close to 8% when moved to TAF, and close to 6% for patients who maintained tenofovir disoproxil. But this was not clinically significant in terms of the difference between the two. Then we always raise a question now. Why lipid levels are consistently higher when patients was receiving TAF? Is it because TAF is a cause, or is it because TDF, actually tenofovir, reduced lipid level? We know that tenofovir has a potent side effect or inadvertent effect, which is lipid lowering effect. So there's a speculation that patients who receive TDF have 300 milligrams of tenofovir in that prodrug. That may have a more potent effect in lowering the lipid level, or significant effect in lowering the lipid level as compared to TAF, which has only 25 milligrams of tenofovir. But take home is patients in this study who received TAF had significant improvement both in the spine and hip bone mineral density. And patients also got better in osteoporosis and osteopenia. We'll see that, answering the next question. Now, TAF is safe and comparably efficacious in patients who are treatment experienced in the first switch study we looked at. But the next question we ask is, okay, there was more bone mineral density loss in patients who received TDF. And also there is more proteinuria in patients who receive TDF. Would that reverse once we shift patients to TAF? Because this is a critical clinical question that we want to ask in practice. Let's see what happened. These are, again, remember, these are treatment experienced patients who are all on TDF and shifted to TAF and TDF. Then you could see that the purple curve continued to increase in actually size. In other words, patients, when they move from TDF to TAF, over 48 weeks, they gained almost 1.8% of the bone mineral density at median. And then patients who maintained on TDF continued to lose the bone mineral density. And this was statistically significant. This was the lumbar bone. And the lumbar bone. And looking at the hip bones, you would see the same thing or a similar thing. Patients who moved from TDF to TAF continued to regain the bone mineral density. We don't know how long these patients were on TDF, but the reversal was apparent. But again, in patients who received TAF or TDF for like 2 years, 3 years, were studied in the hepatitis B study with TAF and TDF, and the reversal was also consistent. And using clinical parameter for classification of bone health, normal osteopenia versus osteoporosis, you would see that when patients were moved from TDF to TAF, over 48 weeks, 5% of the patients were reclassified to have a normal bone or a healthy bone, as compared to those who were continued on TDF, and then 1% less proportion of patients had actually healthy bone. The Emerald study, more or less similar design, but open label. One arm received TAF, another arm received TDF. Patients moved from TDF to TAF. You would see that there was no difference in viral suppression at 48 weeks, even if patients were given TAF for the first time. You would also see that the bone mineral density increased in the hip bone when patients were moved from TDF to TAF. It was the same again in the lumbar spine, significant increase. And at week 48, there was a clinically significant difference in the bone mineral density between these two groups. And imagine over 3 years, 4 years, how much bone mineral density regain that can happen. The lipid parameters were similar to the treatment naive and treatment experienced patients. And conclusion from Emerald study, we have seen that very high viral suppression, maintenance of suppression, no discontinuation due to viral failure, no resistance, but also there were fewer adverse events that were observed in patients who maintained on TDF. Another study of the Gilead Science 1216 study looked at a switch from TDF to TAF with a rilpivirine anchor drug, a more or less similar study, a non-inferiority study at a minus 8% non-inferiority margin in the point of viral suppression less than 50 copies at week 48. The intention to treat analysis showed that there was no difference in viral suppression between patients received TAF from TDF and patients who maintained on TDF. But this slide, I would really like to request your attention to this. This is, again, markers of proteinuria, markers of tubulopathy, markers of proximal convoluted tubule injury. They are independent markers. So these were looked at patients who shifted to TAF. This is the orange curve, the orange bars, and the patients who maintained TDF over 48 weeks from randomization. The positive bars showed that patients who received TDF, and it showed that there was proteinuria, continuous proteinuria over 48 weeks. This is TDF group, and this is TAF group. So total protein to creatine ratio 7.3, albumin to creatine ratio 16.8, retinol binding 21.5, beta to microglobulin 12. But you see the blue bars, which are patients moved to TAF from TDF. All of them have negative values. In other words, the level of proteinuria at week 48 was much less than the level of proteinuria at randomization. And you know, at randomization, they were receiving TDF. So it shows you a significant reversal in the tubular function in patients when they were shifted from TDF to TAF. And fortunately, probably these patients have not progressed to chronic kidney disease. Bone mineral density change, you could see that again, the blue curve, these are patients who move to TAF. They are always higher, showing that a continuous reversal in the bone mineral density among patients who continue to receive TAF. Another study was a study that actually switched TDF to TAF, but from a efavirenz containing TDF to a rilpivirine anchor drug with TAF as a backbone. This is very interesting to see, especially the lipid profile. But keep in mind, efavirenz is lipogenic. It increases the serum lipid level. But rilpivirine is believed to be lipid neutral. Now, then the effect of lipid would be associated with either TDF or TAF or efavirenz. So let's see what happened in this study. So again, they randomized these patients and a double-blind randomization, placebo-controlled trial, non-inferiority study. Again, these are treatment-experienced patients with full suppression, healthy kidney, and were all on tenofovir disoproxil. Viral suppression at 48 weeks was not different between the two arms, which is expected. Renal biomarkers of proteinuria, again, if you look at this, the green bars are tenofovir disoproxil, and the purple bars are tenofovir alafenamide, and all these are independent markers of proteinuria. You would see that with all these markers, patients on TDF, actually continue to have proteinuria, and patients move to TAF actually reverse the degree of proteinuria that they had at the time of randomization or at the time of switch from tenofovir disoproxil. The bone mineral density loss, again, the same pattern of reversal. What they found in this study, interestingly to others, and we wish we can repeat this study in other settings, was that there was a decrease in the total cholesterol, in the direct lipid, low density lipoprotein and high density lipoprotein, and triglyceride in patients who moved to rilpivirine, emtricitabine, and TAF. This is an outlier from all the studies that we see. And the only difference here is that the shift was from efavirenz to rilpivirine, from a lipogenic medicine to a lipid neutral medicine. And that can further strengthen the assertion that we have. Maybe this effect could be due to the fact that there is a smaller concentration or dose of tenofovir in TAF that would not put so much pressure in the lipid level. But remember, whether we have 300 milligram of tenofovir or 25 milligram of tenofovir, there are so many other factors that would contribute to dyslipidemia. But again, this study was very interesting. Finishing off now in the next few minutes, advanced study done next door to Zimbabwe or Namibia or Botswana in South Africa that recruited patients and randomized them into arms. 2 arms contained dolutegravir and 1 arm containing efavirenz. This was in treatment-naive patients who had detectable viral load and didn't have TB or pregnancy at baseline. And the DTG arm were randomized further into a TAF backbone or a TDF backbone. And at week 96, the treatment effect was looked at. And then interestingly, there was no difference, statistically significant difference in viral suppression with an intention to treat analysis between efavirenz and 2 DTG arms. But you would see that the yellow curve, if you look at the slope or the speed at which it reached to this 78-79% suppression, the slow curve actually was, the yellow curve was going up slowly, indicating that there is a lower robustness in viral suppression due to efavirenz, from efavirenz. But if you see the other 2 curves, they went up in the first 1 month. More than 70% of the patients suppressed the virus when they received DTG, and it is not new to us. Dolutegravir possesses a very robust antiviral activity. Close to, in some cases, to 90% of the patients may achieve viral suppression complete at 1 month. But what was interesting in this was that patients who received DTG had significantly higher weight, or proportion of patients were higher, and the mean weight gain was also higher. And it was even more pronounced when patients received TAF and DTG together. And this finding was even more pronounced in women at week 144, and this was seen, and in other studies as well, that TAF and DTG higher, body weight as compared to DTG with TDF, and even much higher when it's composed compared to efavirenz and TDF. So gender was a factor? Apparently, yes. And treatment emergent metabolic syndrome in obesity with either hypertension or diabetes mellitus and the like was again higher in all participants who received TAF with DTG, but it was remarkably higher in women who actually received TAF and DTG, and significantly lesser in men who received TAF and DTG. So again, weight gain has been a concern. It has been a lingering question, and we cannot deny that. Now, finishing off 2 things. One, how do the PK of TAF behave when it is given with rifamycin, especially rifampicin? There was a data from Croy way back in 2018. There's another study that I was able to look at after this, but the finding was that, simply summarizing, there was a significant reduction by 45% in the maximum concentration of tenofovir when TAF was co-administered with rifampicin. Almost half of it is gone because of the fast metabolism of TAF, tenofovir, due to rifampicin. However, what was observed and what was interesting was this. Remember, initially we said the plasma concentration of TAF, tenofovir from TAF, was significantly lesser, but the intracellular concentration of tenofovir diphosphate, which is active metabolite, inhibiting reverse transcription, was significantly high. So the maximum concentration of tenofovir diphosphate inside the cell, inside the cytoplasm of the peripheral blood mononuclear cells, was 81% higher than the intracellular concentration of tenofovir diphosphate that emerged or emanated from TDF 300 milligrams. even when TAF was administered with rifampicin. I would like to repeat this. In other words, what we are saying is, even when TAF was co-administered with a standard dose of rifampicin, the intracellular concentration of tenofovir diphosphate that it achieved was 4 times higher than the intracellular concentration of tenofovir diphosphate that 300 milligrams of tenofovir disoproxil achieved, showing that there is a very, very impressive efficiency of cellular penetration of TAF. This was replicated in another healthy volunteer study as well. This was also a healthy volunteer study. And then subsequently in 2022, the International AIDS Society of the United States made recommendation on for the International Antiretroviral Society. And what they recommended was the use of TXF with XTC, either TDF or TAF, with either standard dose of dolutegravir or favipiravir or raltegravir as part of a standard antiretroviral therapy. Unfortunately, all this evidence, all the scientific clinical practice guidelines from the US and the Europe have not pushed the World Health Organization to include TAF as a preferred first-line regimen, but it can be an alternate, part of an alternate regimen. HIV and hepatitis B, final quick 2 minutes. The Alliance study answered the question that most of us have been looking for, and this was presented last year at the AIDS conference in Montreal, Canada. In this study, they recruited dually infected people, HIV and hepatitis B infected people, who are on treatment, who would be given either a TAF-containing treatment or a TDF-containing treatment, keeping in mind both have good effect on hepatitis B and HIV treatment. One arm received bictegravir with FTC and TAF, the other arm received dolutegravir with FTC and TAF, and they wanted to see the proportion of patients that suppressed the viral load to less than 50 copies for HIV and less than 29 international units per ml for hepatitis B. And the finding in viral suppression for HIV at 48 weeks was not a surprise. There was no significant difference between the TAF and the TDF arm in this treatment-naive dually infected people. But when you look down on the lower graph here, at week 48, patients who received TAF, this is the blue-green curve, 63% of the patients who received TAF suppressed the hepatitis B viral DNA to copies less than 29, and only 43% of patients who received TDF. This was consistent over time, and week 96, actually, the difference was expanded. Not only that, a clinical marker of healthy liver could be normalization of transaminases. And then when they look at the alanine aminotransferase normalization at week 48, 73.3% of patients who started off with TAF and maintained TAF actually normalized ALT, as compared to those who are receiving TDF at 55%, at 18% difference in the effect size, very significant. Another marker was the loss of hepatitis B surface antigen. In other words, either a functional cure or structural cure or complete cure. But you would see here that 12.6% of patients who received TAF lost hepatitis B surface antigen positivity, as compared to almost 6%, and it was statistically significant difference. Another surrogate marker for active hepatitis B viral turnover, which is often linked with liver damage, is the positivity of E antigen. And then you would see that almost 26% of patients who received TAF actually converted from E antigen, positive to negative state, and 14.4%. And looking at, again, the seroconversion to antibody positive state was also similar. In summary of this marathon presentation, we have seen that TAF is non-inferior to TDF in achieving sustained viral suppression, both in treatment-naive patients and also in treatment-experienced patients, though in some cases we are able to see that TAF, the effect of TAF was trended towards superiority. And we have seen consistently superior renal and bone safety profile, at least based on the parameters that were evaluated in all those studies. Biomarkers of tubulopathy and bone mineral density loss reversed over time, and that was continuous reversal as you saw those curves. There were significant increases in lipid levels in patients who received TAF, but the proportion of patients who were requiring lipid-modifying treatment were not significantly higher, but we have other observational studies that showed actually higher lipid-modifying agent requirement in patients who received TAF. But again, this year we have new data from REPRIVE study. The use of lipid-lowering agents in HIV-infected people with high risk of cardiovascular events was beneficial. So probably the addition of lipid-modifying agents in all HIV patients, whether on TDF or TAF, might have its place in the future guidelines. Another interesting instructive finding was TAF achieved significantly higher intracellular concentration of tenofovir diphosphate, which is the active metabolite reversing reverse transcription, inhibiting reverse transcription when it was given with rifampicin. TAF clearly demonstrates superior anti-hepatitis B activity by all the markers that were looked at. Maybe let me finish off this with this quick questions. Now, having seen all the evidence that accrued over time, having seen the clinical practice recommendations of the use of TAF in the US and in Europe, what would be the ethical implication of keeping our patients indefinitely on TDF, especially those with high risk of chronic kidney disease or osteoporosis? I wish us also to reflect what would be the proportion of patients that would have either a higher risk of chronic kidney disease or already established chronic kidney disease? What proportion of our patients would have hypertension and are on TDF? What proportion of our patients will have diabetes and are on TDF? What proportion of our patients are actually in pre-diabetes? Big proportion of whom will be transitioning to full-blown clinically over type 2 diabetes mellitus. Last question, which one is easier to detect in our practice setting? Renal tubulopathy, osteoporosis, osteopenia, or weight gain? I end here. Thank you so much for your patience, and back to you, Dr. Jackie.
Thank you very much, Dr. T. That was a brilliant presentation. I'm going to kick off with a couple of questions that were asked by people before we started the talk. And I'm going to direct this question to Dr. Agnes Katsira because she has a very strong business background. And the question is, good morning, maybe out of interest, can we look at a cost analysis between the two regimens? And what are the barriers to switching given the availability of regimens, particularly TAF-LD? So, Dr. Agnes, I'd be very grateful if you'd unmute yourself and answer that question.
All right. I would like to thank Dr. Tadesse for that actionable and very insightful presentation. Then if you're anything like me, if you've passed through business training, one important aspect when it comes to conducting a cost analysis of two drugs, in this context, TAF and TAF-LD, there are several factors that need to be taken into consideration that is beyond the perceived price or cost, which is tied to the market price. So one important aspect we really need to consider is the value to the patient, which is a concept most healthcare providers are not familiar with. So at its core, the overarching value of healthcare is to maximize value for the patient, which is defined as achieving the best possible healthcare outcomes that matter. The outcomes should matter to the patient at the lowest cost possible. So this definition recognizes that the cost benefit is actually a subjective issue and can differ from person to person. So it is important to take into account the individual circumstances, as Dr. Mekonen has mentioned, patient preferences, and the needs of each patient. So regarding the movement between TDF and TAF, we now know that for a particular group of patients, particularly the elderly, those above the age of 50, those with pre-existing or new renal impairment, those with comorbidities, that increases the likelihood of renal failure, such as diabetes and hypertension. So we need to take into consideration all these factors, and this personalized approach ensures that the cost of healthcare actually aligns with the specific value that each patient places on their health outcomes. Because in the HIV program, now we are talking of the fourth 95, which speaks to the health related quality of life. So additionally, considering the patient value actually helps to prioritize resources and allocate them effectively, ultimately leading to a more efficient and patient-centered system. So firstly, the price of each drug obviously plays a crucial role in determining the overall cost. As for TAF and TDF, the market prices are comparable. But beyond the price, as I've mentioned, you need to consider aspects such as the potential long-term benefits associated with each regimen, paying attention to such matters as the frequency of dosing is the same for both drugs, the duration of treatment is the same as for the long term, and also the efficacy and the safety profile that Dr. Mekonen has highlighted. And furthermore, obviously, the accessibility and availability of both drugs should be taken into consideration to ensure that the patient has continued access. So here in Zimbabwe, both drugs are now available and accessible in both the private and public sectors, which has significantly improved the options for the patients. Then in terms of the barriers, according to the question, they depend on host factors such as the age. There are some ages where we say it's not recommended. There are system factors such as the availability, presence of comorbidities, interactions. Then there's also the absence of evidence to support its use in certain populations, such as the pregnant women, which may pose a barrier in it for its use in certain populations. So briefly, with regards to the cost benefit, those are all the factors that you need to consider beyond the market price of TAF or TLD. I hope I've answered the question.
Thanks very much, Agnes. And I think you also answered another one of the questions, which is, are we at the point where we need to individualize treatment? And I'd like to open that question up to each of the panelists, including Agnes. I think you've already answered it with your last answer, but I'd like to ask Dr. Lloyd or Professor Lloyd whether he feels that we're at the point where we need individualized treatment. And I'd also like to ask Dr. Agri, what is the role of point of care biomarkers in detecting renal damage in patients on TDF? So can we start with Professor Lloyd Malema, answering where you think whether we're at the point where we need to start individualizing treatment?
Thank you. Thank you so much for inviting me and to really think about individualized treatment for people living with HIV. We have individualized treatment for those that have highly treatment experienced. Those won't be on third line. We do not currently have individualized treatment for those on first line or second line because we largely use the public health approach. In resource-limited settings, we are not ready for us to have individualized treatment because of the various sorry for that, because of the various limitations we have with resources. So still where we are highly donor dependent, where we depend almost 80% of the overall HIV budget in sub-Saharan Africa is supported by the donors. We cannot go into this individualized treatment. Individualized treatment would need thorough viral load testing, thorough also resistance testing as well. But we have some research models which we can look at. Dr. T has highlighted a number of them where you can use TAF. And those trials have demonstrated really that even using a public health approach, you can see which individuals may benefit from TAF. Where we may need just specific use of TAF in certain populations are populations who may have certain comorbidities, those with renal insufficiency, those with bone disease, but also children as well. You may try and use individualized treatment. As of now, we have evidence that using the public health approach, we can use TAF and with very, very good outcomes. There's one trial, hopefully we will share this, the 144-week data for the Vicent, where we have extensively used TAF, and it's a first trial where we have observed patients who are on TAF for 144 weeks who are using TAF as a second line after failing TDF in first line. And I think it's such trials which we need to emphasize on together with the Nadia trial. There's a second line trial as well from Kenya. There's also another trial from South Africa. So these second line trials, they do provide us with evidence on how we can use these molecules using a public health approach. Otherwise, using an individualized treatment would be very difficult for now in these limited settings. Thank you.
Thank you very much, Professor Malema. I'd like to ask Dr. Agri now, what is the role of point-of-care biomarkers in detecting renal damage? And with your background in nephrology, what is your feeling about which way we should be going with TDF and TAF?
I think, thank you so much for inviting me. And thank you, Dr. Tadesse, for that comprehensive presentation. So with the point of care monitoring for kidney injury in HIV patients, I think let me mention that so there are several biomarkers currently on the market, and I'll just mention probably a few. Some of them are in saliva, like the urea nitrogen. Some of them are in urine, like the neutrophil gelatinase associated lipocalin, the KIM1, cystatin C, and interleukin 18. And there are some of them that are measured in blood, like the cystatin C. We also have, there's a difference between those where we look for tubular dysfunction and those we look for reduced glomerular filtration, and so we can use different modes to look for them. Now, what's the role of point of care? I think for me, the first advantage that biomarkers give is that specimen collection might get to be better. For example, we can use either saliva or we can use urine instead of getting blood for us to look for these biomarkers. The second advantage is early diagnosis. As you know, we struggle with the standard gold, which is currently the creatinine or EGFR. We have to wait for some time before creatinine goes up because of the factors that affect creatinine. Whereas some of these markers within hours or within few days, we should be able to know that there's something happening within the kidney. And so early diagnosis is an advantage for these biomarkers. The other advantage point of care brings is probably in the long term, it will require less expensive equipment as opposed now where we have to send samples to the lab and use a very expensive equipment for us to run tests. At the same time, this will mean that we have less expertise for someone to run those tests. Someone probably starting from a maid, as long as we teach them how to interpret the results, they should be able to tell us that, look, I think this patient has AKI or they don't have AKI. And so this is one of the advantages that a point of care brings about. The other one is that we should be able to expand accessibility to places where unreachable places. For example, at the moment, if you came into my countries, there are certain places where I cannot run a creatinine. Whereas if a point of care facility came in, would be able to do these tests anywhere, including the most rural places in the country. And therefore, I think that they have a place in the current setting, especially in the developing countries. The only issues, obviously, that we need to sort out is that we're still not very sure of the total implication in terms of clinical implications. What is the true sensitivity and validity of these tests? Those are some of the questions that we need to answer. Should we include all those tests maybe in one bundle and be able to make a prediction from those tests? And what is the decision after we have diagnosed AKI? I think that some of those questions have not yet been answered. But all in all, I think that when we have a point of care into our in sub-Saharan Africa, especially the SADC area, I think it will go a long way to prevent complications of AKI. At the moment, as I can tell you, is that to treat one AKI is very expensive. To just have dialysis and treat them is very expensive. So we should be able to catch a lot more and prevent more from progressing into severe complications of AKI, and we should be able to intervene early if we have a point of care for these biomarkers. What was the next question?
I think the main one was what is the role of biomarkers? And the second question was, what would be your personal preference in starting a patient on TDF or TAF? But we are asking a nephrologist, so I think we know the answer to that.
I think the answer is obviously not straightforward. Obviously, I think from the presentation that has already been done, I think we know that TDF is not as bad as probably from the studies that have been done, I think already presented by Dr. Tadesse. But I think that we have something to think about, and what to think about is some of the points that he has brought out. We know, for example, that our population is aging, and therefore, as they age, there's an issue of the osteoporosis, there's an issue of kidney function. There's also a lot of comorbidities. We know for sure that, especially in my country here, we know that hypertension is probably more common among the HIV individuals than non-HIV. And we are seeing a lot of diabetes as well. And as you know, in our population is that people use other extra drugs apart from what we give them in the clinic. And those extra drugs, we don't know the implications on their kidneys. And then we have an issue of availability of tests. We are discussing the biomarkers here. These biomarkers are not yet available, which we need, and I think we need them as soon as possible. But creatinine is not available on the ground. And therefore, given all those, we know that most of our patients, when they come, they'll have all those comorbidities. HIV does not exclude comorbidities. And therefore, it is nice that we start stratifying these patients or segmenting them into groups that we think can be managed. in this case, for example, a woman who's above 45 years, we know that they are likely to have osteoporosis. So why not take them to TAF? A male who is above 50 years old, they are likely to have hypertension, they are likely to have diabetes, they are likely to have also osteoporosis. So why not segment them so that they can be switched to TAF? So given that scenario, for me, I think that TAF probably outweighs tenofovir, and probably in the absence of creatinines, I would probably put most of my patients on TAF, and only leave those that we think maybe have TB and pregnancy, where we have to make those decisions whether they should be on TAF or not TAF. I think that would be my response.
Thank you very much for that. That was excellent. I've got a question here from Dr. Landman. There's two questions from her. Unfortunately, she couldn't make it tonight for personal reasons. It's her son's prize giving at the school. So given the rapid decrease in viral load with DTG, is there a place for a regime where DTG is used for 2 to 3 months until viral load is suppressed, and then switch to an efavirenz-based regime if weight gain occurs? Because weight gain, particularly in the private sector, affects compliance, particularly in women. And I'll throw that out the whole panel. Anybody who wishes to comment on that, please feel free to do so. Dr. T, I'll put you on the spot for that. Oh no, Dr. Lloyd, Professor Lloyd, go ahead. Professor Malenga, we can't hear you and your screen is frozen. Perhaps switch to your video and we can just get you on audio.
Question. This thing yeah, just scenarios you can guys there following the yes within be used in.
I think we may have lost Professor Lloyd. Dr. T, would you like to respond to the question?
Thank you. The line was breaking when you were speaking as well, Doc. May I kindly ask you to quickly summarize the question? I hope you can hear me, right? Yeah.
Yeah, we can hear you well. So the question is, given we understand that DTG obviously brings down the viral load very quickly, is there a place for switching DTG once the viral load is suppressed? Is there a place for switching DTG to an efavirenz-based program if the patient is experiencing significant weight gain, particularly in women, because Dr. Landman is concerned about compliance?
Yeah, thank you very much, Doc. I think it's a very important practical question and is going to remain also relevant as we go forward, especially when we put many patients on DTG. Let me summarize by saying this. We have seen DTG is a wonderful drug, robust viral suppression, durable viral suppression. And the data that came from Zambia, coming from Zambia, is also indicating that even after 3 years, great activity, which they will get soon, I hope. But also what has been continuously emerging is that patients who receive DTG not only getting higher body, but also getting metabolic syndrome, treatment emergent hyperglycemia and established diabetes mellitus, and also hypertension. And also dyslipidemia, higher risk of predilection to dyslipidemia. We're not saying these are happening in all patients who are on DTG. So this being the emerging trend that we're observing in patients who are getting DTG, all right. On the other side, having observed for years that tenofovir disoproxil with efavirenz, or even TAF with efavirenz, knowing that tenofovir and efavirenz are comparable in efficacy, it should still give an opportunity for an alternative regimen for patients who have established treatment emergent metabolic syndrome. So this is one area where we may have to individualize treatment. So yes, Doc, I think we have the opportunity to look into shifting patients from dolutegravir to efavirenz, if we have seen that those derangements in terms of glucose levels, hypertension, and also dyslipidemia. That said, I think it is now clear to everyone that the use of efavirenz 400 is superior in safety profile to efavirenz 600, at least to some extent. And we have not seen the long-term complication of efavirenz 600. So if we decide to move dolutegravir to efavirenz, then it is advisable to move to efavirenz 400. So it will be a case by case. It will be an individualized approach that we would have to follow. I hope that addresses the question, Dr. Jackie. Back to you.
Yeah, that was a great answer. I've got another question here, which I think is from Professor Sibanda. Thank you for the excellent presentation. Your last question is rhetoric. He's going back to a bit earlier and needs answers. You ask why TAF is not recommended by WHO. My question is, what is the role of academic and professional bodies like this one and other African organizations in influencing WHO policy?
I don't know if I'm able to pick that question.
Yes, go ahead.
And just compliment on the wonderful answer from Dr. T over the use of efavirenz. I think one principle also which you may need to lay is that because of the wide NNRTI resistance, as you switch to efavirenz, it would be good to also have to also have baseline resistance if it's available to efavirenz or any NRTIs as part of the individualized treatment. WHO right now has limited role for TAF, so it's in the guidelines. I'm part of the WHO guidelines development group, and we did consider TAF. It very again tough argument to include TAF in guidelines, but we limited its use to those with osteoporosis, as Dr. Mwemba did discuss, and also those with kidney disease, and children as well with the age band, with a weight band above 25 kg as well. We think that there is a greater role. Now we have data of TAF in pregnancy. We have trials that have evaluated TAF, the IMPACT trial, and reported as well. The Vicent trial as well has seen that TAF has good pregnancy outcomes. And there is now a high consideration of TAF under WHO to be included in the guidelines with a wider role. However, we still have data. We're just starting a trial in about 2 countries of TAF and rifampin, and also TAF with rifapentin, because if we can have data to prove that the clinical outcomes in the HIV-infected people following like what Dr. T did present in the HIV negative as well, and those we think that we may have a greater role as well, filling in the gap we have over the TAF and rifamycin's use in general. We think that if we have that is the missing piece, then we can have TAF being used in a wider sense under WHO, and there would be really a good argument to say that we need to have a broadened role. Another area I think is the children. We have smaller molecules now being advocated for. Already TAF with bictegravir and FTC is used in children in the US and in Europe. So we still need to get this information to the guidelines development group and for WHO to really consider it highly for its wider role. Thank you.
Thank you very much, Professor Malenga. I would like to now transfer across to Oshakati, to Dr. Enos Moyo, and I'd like to ask you about studies that you know about that show the cost effectiveness of TAF versus TDF.
Good evening, everybody. Thank you, Dr. T, for the presentation and all the guys who were talking about giving answers to the questions. I would like to add to what Dr. Agnes has said about normally when you are looking at cost effectiveness, you are not just looking at the price of the drug. It's one of the minor things that is looked into. You have other things that you have to look at, such as the quality of life of the patient, their survival, and also you look at the budget impact to the, especially where it's supposed to be given in the public health sector. So I couldn't find any cost effectiveness study which was comparing TDF and the combinations we have here in Southern Africa. But in Italy, there's a study that has been done for cost effectiveness. This was looking at boosted regimens, such as they were comparing TAF together with emtricitabine, corbistat, and elvitegravir. This was compared to TDF, emtricitabine, elvitegravir, and the corbistat, or TDF, emtricitabine, darunavir, boosted with ritonavir, or TDF, emtricitabine, together with atazanavir and ritonavir. It showed that among these three combinations, the one with TAF was dominant over the three other regimens. And the main issue that came up was they were looking at normally the tests that are done when someone is on TAF compared to those who are on TDF, and also the follow-up of the patients. How often are they seen? This is very important because every time a patient goes to see a healthcare worker, there is a cost to that. The other issue that should also be considered when we are changing maybe from TDF to TAF, for example, or TAF to TDF, whichever is going to be used in this situation, we are looking at TAF, which has more advantages, is the budget impact on the budget impact. Like, for example, the Namibia, are they going to be able to afford at that point to change from one regimen to another? But in this case, we have an advantage where TAF is has less side effects, and also the price, basically like in the Namibian market and other markets like in Zimbabwe, you look also, I don't know about Zambia, but the prices are almost the same of these of the combinations. So what's important now is the test that will be done. We are looking at TDF with renal function, creatinine clearance, and all that. And we are also looking at maybe lipid profiles for patients on TAF, which might be cheaper. So all those factors will come into to give us a more cost effectiveness drug in TAF regimens compared to TDF. Thank you.
Thank you very much, Dr. Moyo. And I have another question for you, given that your last talk was on PrEP. Looking at the safety profiles of TAF at its high cellular concentration compared to TDF, do we have any study that is looking at TAF for PrEP use?
Good evening, Jackie. Hello.
Hello. Enos, is that?
Hi, Doc. No, it's not me. It wasn't me. No, I haven't looked at. Last time I was checking, I didn't really look at studies that were comparing TAF and TDF, so I'm not very sure about that one.
Just as another question that I would like to ask is, when
can I go ahead and just answer that?
Sure, please do.
Yeah, so TDF and TAF has been compared for PrEP. And in fact, one of the landmark trials which were led to approval of TAF for use in PrEP with FTC was comparing the oral PrEP of TDF with FTC. And the only limitation is that trial, it's an HPTN trial, was only in the MSMs, and it did not look at the cisgender. We are just about to complete a trial in Zambia, funded by Gilead, where we have TAF with FTC in the cisgender. And so far, the results are comparable with less transmissions on TAF, and this will be presented at the European AIDS conference in 2 weeks' time in Poland. And we also have an abstract ready for CROI as well. So those are the trials which we have. So in the MSMs, there is data, and there's now this emerging evidence in the cisgender as well. But also HPTN is also doing another one in the cisgender in Africa and also in the Caribbean islands. Thank you.
Great, thank you for that answer. One of the questions I personally would like to ask is, after the PrEP, the long-acting extended delivery medications, does that have any effect on renal function or weight gain? And that question goes to Dr. Enos.
Hi, Doc. Please repeat the question. I didn't hear it clearly.
The long-acting extended delivery injectable PrEP, does that have any effect on renal function or weight gain?
If we are looking at the long-acting injectables like cabotegravir, some studies have shown that especially women, a few women, they gained a bit of weight, but it wasn't that significant compared to those who were on other, because that one was comparing the oral PrEP and cabotegravir. So the study, I can't remember, the study showed that cabotegravir slight weight gain, but it wasn't significant compared to the oral PrEP. That's the only study that I could pick up when I was looking at injectable cabotegravir. On renal function, I'm not very sure on that one.
Okay, that's great. Do any of the other panelists have a comment on that?
Yes, indeed. So for long-acting cabotegravir, the renal profile is okay. No major incidents. And again, we looked at this data at the DSMB when we're evaluating whether to go ahead and release for safety monitoring reasons and say if it's safe enough. So we did not see any safety events which were concerning for those who are on long-acting cable. However, for those who are on long-acting treatment of cabotegravir with rilpivirine, it was mostly the issues concerned of rashes, which are largely related to rilpivirine, and that is for treatment, but not for prevention. And as rightly said by Dr. Enos, slight weight gain for cabotegravir, and I think this is just a phenomenon for most of the instis where there's slight weight gain, but not as reported with DTG combined with other NRTIs. Thank you.
Okay, thanks very much.
And just to add on that, yes, in fact, the renal elimination is less than 1% with the long-acting injectables, and therefore no dose adjustments is needed, even in severe renal dysfunction.
Great, thanks very much for that answer. That I think some of the long-acting injectables, hopefully with time, will come into treatment regimes, because I think they will make a huge difference with compliance. I have another question here.
Dr. Jackie, maybe just quickly to complement on that, I fully agree with Dr. Agri. I was going to mention that point as well. But one other element that often crosses our mind when thinking of long-acting cabotegravir is the simplicity of administering the injection in a peripheral setting in a rural Africa. So that has caused a psychological barrier, I think, for many practitioners and policymakers. But there was one interesting study that was shared this year showing the administration of long-acting cabotegravir for PrEP in people who are non-medically trained community healthcare workers or equivalent of community health workers in the developed world. And they were effectively able to administer this and maintain impeccable adherence of patients who are receiving these injections. So I think the implementation science part of it is also will not be a barrier, especially in countries that have a strong, robust community health care working programs. Over.
Great. Thank you very much, everybody. There are other questions in the chat, but I think they've actually been answered by the panelists. We've got 3 minutes left. So I'd like, if there are any closing comments, if any of the panelists want to say anything, can we start to close? And it would be great to get a closing comment from each of you. So can we start with you, Dr. T, and then we'll go to Dr. Agnes, and then to Dr. Agri, Dr. Enos, and Professor Lloyd. So closing comments, Dr. T.
Yes, thank you, Dr. Jackie. I will be very brief here. Thank you, Intellectus Campus. Thank you, Avacare. Thank you, the entire panelists, and also the entire community. We continue to learn together. I think one point that I would really like to say, in line with individualized care for HIV patients, is to bring in the notion of differentiated healthcare service delivery for people living with HIV. Our care, our treatment, and all other interventions should really speak to the needs, the particular specific needs of our patients. I think the growing comorbidities, the side effects that are emerging and we're seeing can affect longer-term treatment outcome. To this end, I think it is really time for us to look into the possibilities of consulting the DSD, the differentiated service delivery, whereby we'll get a room to treat every patient as an individual with different varying needs from the other. And using TAF, using TDF, using dolutegravir, using efavirenz, where and wherever applicable to that particular patient would be important. Public health guidelines are guidelines. They guide practice. It does not mean that at all times we have to follow them, even when patients have individualized needs. So please, let's uphold the principles of differentiated service delivery to address the individual needs that individual patients have. Thank you. Over.
Thank you very much, Dr. T, for that. Dr. Agnes, can I hand over to you for some closing remarks?
Yeah, thank you so much to the presenters and the panelists. Thanks so much, Dr. Stone, for facilitating the session. Personally, I think I've actually learned more than I've contributed. And just to add on to what Dr. Mekonen has said, especially in our context in Zimbabwe, because I can safely say to some extent we've moved towards the one-size-fits-all approach to management. We've moved away from the supply-driven system where everything is organized around availability, cost, etc., etc. Everything here in Zimbabwe, it's now differentiated. We try to tailor everything to the unique characteristics and needs across the entire HIV care cascade. That is from the HIV testing, where we now have differentiated testing strategies based on risk profiles. We now have differentiated testing algorithms for the general populations, key population, pregnant women, breastfeeding. And this approach extends to even treatment initiation as well. At monitoring is now differentiated through to adapted adherence support. So yeah, within our programs, we now have algorithms that are designed around the specific needs, general population, key populations, etc. So it actually brings to the spotlight the issue of just familiarizing ourselves as healthcare workers, refer to the guidelines whenever we are not sure. Thank you so much for this session.
Pleasure. Thank you, Agnes. Dr. Enos, can I hand over to you for some closing remarks?
Thank you very much for the presentation, everybody. What I wanted to highlight also, like Dr. T had said, is more of the injectables. Actually, people might be scared to start injectables for, especially for prevention because of the injection. But a few implementation studies have shown that most of the people who want prevention, HIV pre-exposure prophylaxis, they would actually prefer the injection compared to the oral medication. So it's very important that as people bring in policies, they look at the needs of the patients themselves. And let's not forget the adolescents and the young people, because these are impacted by HIV more than everyone else. And some of these drugs are not yet studied on the under 18-year-olds. So as research comes in, we shouldn't forget these ones because they are impacted more, especially in sub-Saharan Africa, by HIV. Thank you.
Thank you very much, Dr. Moyo. I'm now going to hand over to Dr. Agri. Can you give us some closing remarks?
Thank you so much again for inviting me specifically. Just to mention that in Africa, and specifically sub-Saharan Africa, that we are, as a race, Black individuals, we are prone to CKD especially, we carry that gene. And our HIV population is getting older and older. We have common morbidities among these HIV individuals, hypertension, diabetes. We tend to use non-conventional conventional medications along the way. And therefore, we have also adolescents and young children that are still growing with those bonds. We need to protect the bonds and we need to protect those kidneys. And therefore, those special populations, I think that we all need to start thinking that maybe it is better that they use TAF and we move them from TDF, while we still search and probably find a much cheaper kidney biomarker that we can use to monitor those that are on TDF. Thank you.
Thank you very much for those closing remarks. And we're going to leave the finale for Professor Lloyd. Can you give us your closing remarks?
Thank you. I think we have an opportunity for us to slowly introduce what you may call individualized treatment, even in the public health approach. And really, TAF has been a molecule which has been underutilized. TAF has been used for years in resource-rich settings. And I think we need to use it at a wider scale, especially for those individuals who may think that may be at risk of kidney disease, but also the pregnant population. Currently in the US, it's a preferred drug for those who are pregnant compared to TDF, the children as well. And I think we need to have a bigger role for this molecule. Thank you so much.
Thank you so much, Professor Malenga, and thank you to all the panelists for agreeing to join. I'm going to hand over to Obi now for the closing of this session. And I'd like to thank everybody on the call. There have been well over 200 participants on this call, and they've actually stayed on the call for an hour and a half, which is credit to the panelists and to Dr. T. So Obi, can I hand over back to you just to close the session?
Dr. Jackie, thank you very much for having moderated this session. A great pleasure. Dr. Tadesse, Dr. Agnes, Dr. Enos, Dr. Agri, Prof. Lloyd, Dr. Cleophas. Words cannot express enough our gratitude for your having participated, and Dr. T for having delivered the keynote address for this session. Extended gratitude from ourselves as the team at Intellectus Campus, together with the team that we work through Avacare Health to work to advocate these topics. So extended gratitude all around for the for the audience that sat through the session. The session wouldn't be a success without your participation, together with your being a party to our audience. So thank you as well for making the time. A reminder, colleagues, there is a link that is on the chat. We will not be able to circulate your certificate for having attended the session without you completing your attendance details per that link. So if you can please complete that to enable us to circulate your certificate. Once more, extended gratitude. We will be having another session next week, Wednesday, the same time, 6:30 CAT. A very good evening.
Thank you, everyone. We will leave the link open for another 5 to 10 minutes. I think we will